So over to you, Bruce.
Okay, thank you. So it's actually really nice to be able to talk clinically. So I work very closely with Emily and Harold, leading the CAMHS CAG, where we have nearly 700 staff actually, and I'm typically talking about managerial things or initiatives that we're undertaking, so it's so nice for me to put my consultant psychiatry hat on, if you like, and talk about the work in the team I'm really proud to be part of. And so, there we are. So I work in the National Service for OCD, body dysmorphic disorder related difficulties, which interestingly, I've got a slide up here of DSM-5. I should switch this as well. We could put up ICD-11 after the 18th of June with the publication of ICD-11. And it's an interesting time actually, because in both manuals now, OCD and the related difficulties have been lifted out of the anxiety disorder and been gathered together by disorders that are typified by compulsive behaviours and are studied and collected. And for the first time under both manuals, body dysmorphic disorder that has migrated around, you know, it's been considered as a psychosis, it can respond to anything that the psychosis responds to, so it's jumped around and now sits within these category of difficulties of compulsive behaviour. And it's an exciting time for us in the UK actually, because the first national survey that includes an appraisal of the incidence of body dysmorphic disorder will publish later this year, and I think it's going to be quite a telling time, and hopefully our service will be on the forefoot of being able to respond. It's an area where all of the research is still to be done. Now, this is a project stage, so I'm going to try and sprint through perhaps 9 brief projects. And my focus actually, we're an NHS team, we're a National Health Service team, and I'm really proud to work in this service because we really collect a lot of data. Each child who goes through our service, by the time they exit the service, if they complete all the measures, we have 7,000 data points on them. You know, we record everything, we have everything in our electronic measures, and that sort of richness of data allows us to really refine what you do. And those of you in the audience who were earlier in the week at the Master's course, Eric Taylor gave a lovely presentation just helping people focus on the kinds of research that they can do within their everyday clinical practice. And it is that sort of collection of routine data that has helped us shape and develop services and treatments that are effective for OCD and BDD and really forward this. So this is just to ground our thoughts. These, of course, are the common range of obsessions that you see. I'm not going to talk about transformation obsessions. We have team members who've done research on that, and it's often confused as psychosis. I will present something on commonly presenting unwanted sexual thoughts or so-called forbidden thoughts. Those, of course, are the common compulsions. I wanted to put up this slide because this is just, you know, it's a great starting point working with OCD because it is an eminently treatable disorder. We actually have really brilliant treatments for OCD. The combination of cognitive behavioural therapy and SSRI are some of the most efficacious treatments that exist within the textbook of mental health. And this is just some aggregated outcomes through our clinical service for some of the young people who had moderate severity OCD. So on the y-axis is the CyBox score, which is the international gold standard. Our team typically takes cases who are severe and treatment resistant, but this is the outcomes over time through our standard treatment protocol for kids with moderate severity OCD. And you can see by the end of follow-up, and by the end of treatment and in follow-up, typically 80% of young people who use our service are no longer have a score that registers as OCD, if you like. And the reason I put this up is we know with good quality treatment, 80% of people will respond to treatment for OCD. So everyone is always chasing the 20%. And that is what much of our team's research tries to focus on. So what about, I meet the 20% in everyday practice. And so we look very closely at what we do. We're rather perfectionistic and manualised, and we closely monitor our adherence to protocol. And one of my brilliant colleagues, Georgina Krebs, wrote a fantastic case series where she looked at a group of people who come into our service under a particular contract for the most severe treatment-resistant cases in the UK. And she looked in detail at 43 of those cases. And actually, if we applied our manualised treatment, our standard therapy, actually just shy of 60% of those young people would respond to treatment. And actually, we got a quarter of them into remission just by using the protocol. So this is a nice project just to show that don't forget the basics. The NICE guidance is very clear and delivers good quality outcomes in a huge number of cases. And what Georgina did that was helpful was just pick apart what had happened in those young people's journeys before they encountered our service. And actually, more than 95% of the people who were deemed treatment resistant, if you looked at their adherence to protocol for CBT, it wasn't of a quality. There were technical failures in 95% of cases who referred. So it was an important project that just emphasises that getting the basics right really makes a difference. So what about that 20%? Which aspects of therapy have we been able to look at through the routine of our NHS service? So Dr. Jassy, who's one of my consultant colleagues, who'll be standing by a number of posters later, sitting up here, and she has become really expert in refining and looking at the protocol of treatment delivery for young people who have obsessive-compulsive disorder in combination with autism spectrum disorder. And actually now 30+% of the young people who go through our service have exactly that combination. We are seeing a huge number of people referred into services who are correctly diagnosed with ASD, and we meet a huge number who don't. People with autism spectrum are prone to developing OCD, but what Amita showed here, when we looked at their data and outcome, when we applied our standard treatment protocol, they would respond and a number of them would go into remission, but no surprise, the rates of response and remission were poorer for people who had that combination of ASD and OCD. Now, I don't have time to present it, but Amita has then subsequently gone on to research a refined manual and a different approach to treating those young people, and we're going to be publishing that as a book shortly. Quick plug there. Right. Moving on to something else that we found. In looking at our data of the kids, we have huge numbers, on many hundreds of people who have had OCD and gone through treatment. And actually, when you look at them in detail and look at their symptomatology, 25% of young people with severe OCD have eating difficulties as a consequence of that. And for 3% of the cases who come through our service, those eating difficulties are so severe that they are starved. And it was a constant question for us. We would struggle to treat well those cases of OCD where significant starvation was an issue. So this again is a nice example of a straightforward project where if you've got the data you can take a look. So what we did was look at 22 kids who were starved, so their mean percentage BMI was less than 85% at our assessment, and we matched those for age across a range of matching criteria. And the SIBOX score, which is the gold standard measure of OCD, we looked at that at the beginning and end of treatment. And so in the table at the bottom right there of the slide, you can see for the healthy weight individuals that the SIBOX score of 28 is just shy of the severe range, above 30 is in the severe range. At the end of treatment, that's before follow-up, we were at 14. Below 12 is in the normal range. However, if you had significant starvation, such that your mean percentage BMI was less than 85%, there was in effect no change. So CBT was ineffectual in that population. And that sort of validated what we had seen and understood in our treatment approaches. But lent us the ability to then develop a more detailed care pathway around feeding before going into CBT. And I thought it was a really lovely example of how just looking at your own data and doing a decent project shapes the way you can approach treatment. Here's a project we did looking at forbidden thoughts. So these include the very common phenomena of violent intrusive or sexually intrusive imagery. And, you know, a lot of people, as I highlighted earlier, maybe haven't had appropriate treatment. And so we meet a large... OCD doesn't go and find nice thoughts. You know, I love dogs. It would never plant images of Labrador puppies in my head because it wouldn't stress me. OCD is a bully, and it's going to go and find hideously stressful thoughts. So it grabs thoughts of sexual imagery or violent imagery, injuring your family, and that is going to do really well within an OCD cycle. And you can imagine, if you're in community practice, that if you're meeting a child who has really violent, intrusive sexual imagery, for instance, in relation to family members, that it's quite frightening to start CBT in that context. So it's important to study, and we wanted to look at just how common this is within a child population. It had been well described in an adult population, so we had a careful look through just shy of 400 cases who'd come through our service, and exactly the same as an adult audience, 28% of the kids who use our service have sexually intrusive imagery. People typically have multiple obsessions, and lo and behold, children are no different to adults. They have sexually intrusive imagery. And that is a really important thing for us to know. And what we now do in our approach to treatment, we give parents the paper that is in my illustration on the left, because ultimately it shows this is common, it helps you explain that OCD is a bully. And what our paper showed when we looked at the outcomes in treatment for these people is that those patients respond just as well to anyone else. So having a sexual or a violent intrusive image as part of your OCD is no impediment to treatment. And interestingly, we see a huge number of cases who get referred through our service where people have been honest enough to share their sexually violent thoughts, and they've been referred to children's safeguarding on account of that. So you have to understand that symptomatology, and sometimes it does require specialist support to kind of be bold enough to understand that in the context that it exists. But that project has been really important in allowing us to understand the phenomenology of OCD in more detail. Now, I see Rebecca from Maudsley Charity, thank you, at the back, and we're really proud to have had funds from Maudsley Charity to look at the issue of ethnicity in OCD. OCD is as common in all populations, regardless of ethnicity, and what we've been able to show, unfortunately, is that people from black and ethnic minority communities are struggling to get into services. And so we have a project to both study that and disseminate information, as well as deliver a better quality of service in those communities. I'm going to rush through this. We've been looking at, as a project, the delivery of high-quality treatments, the recommended treatments under NICE, and actually over time, people accessing the best quality of service has gone down. There was an expansion in CAMHS services, and sadly, with that expansion, very often has brought people being put into therapies which we know are not as evidence-based as they could be. So in order to try and tackle that, we're involved in a multi-site trial between here and the Karolinska Institute using internet-based CBT to get CBT to a wider population. We are also using multi-family group therapy now, and earlier this week some service users supported us in getting that agreed for National Health Service funding, so we now have a means and the support to deliver that treatment under the NHS. And what I want to say one final word, and I shall stop, about body dysmorphic disorder. This is something which we have been engaged with and want to deliver much more research and increase the knowledge of body dysmorphic disorder. Body dysmorphic disorder is a common condition. Up to 2% of the adolescent population have impairing body dysmorphic disorder, and it probably has the highest suicide rate and self-harm rate of any mental health condition. It's not a race to the bottom, but often colleagues who work with eating disorders talk about the very high rates of morbidity and mortality associated with eating disorders. 50% of patients who have a diagnosis of BDD make attempts on their life, and yet these people are not in our services across the UK. This is a disorder typically associated with tremendous shame, and really there's been very little quality research for young people understanding what effective treatments are out there. Our team was lucky enough to get funds to do the first ever CBT trial for young people, a randomized controlled trial, and this is the one slide, I promise it's the finish, last project, looking at the evidence base for CBT for BDD in young people. And in essence, we showed there was a strong effect size for CBT, an effect size of 1.7. 50% of patients responded, 50% did not. You know, there's plenty of work to do here. And at just shy of a quarter of the patients were in remission, and those gains lasted to 12-month follow-up. We have refined our treatment protocol in light of that research. Last slide, just to thank collaborators. There's a huge number of people who've been involved in driving forward these projects within routine clinical practice, as well as funded research, which we thank people who've supported research, but a lot of this is just driven through standard NHS clinical care. So thank you for your attention.